Why don't we go ahead and just start the introduction to the rotator cuff now for a few minutes. So we already talked about impingement. Now, and impingement, one of the reasons why it's important, one, it produces symptoms. It can limit athletic play, as we talked about, but it also damages the rotator cuff, as we saw in the previous lecture. And so now I'd like to talk about the pathogenesis of rotator cuff disease. For a long time, people thought impingement was the primary reason people develop rotator cuff tears. And now we believe that the primary reason is actually primarily straining the tendon beyond its condition, usually from overuse, and it does not require bony impingement to do that. And bony impingement is probably a less common primary cause of rotator cuff disease than was thought in the past. So I'd like to talk about a little bit about pathogenesis of tendon disease, and then we'll look at what tendon looks like on MRI. So the pathogenesis is with use of any soft tissue structure. If you pull it or push it or anything, you can produce microscopic collagen tears of the collagen fibers. There is a repair mechanism in the body where it goes in and repairs that, just like there is a bony repair mechanism that we'll talk about in much more detail when we get to talking about bone diseases. But there are soft tissue repairs. If you have a lot of repair and a lot of injury, the repair can't do a perfect job, and that leads to loss of the normal microscopic structure of the collagen fibers, which leads to increased fluid, fraying of collagen, the strands of the collagen, that leads to increased water imbibition by the tissues and increased signal intensity on the MR images. And then finally, if you get enough of that, you lose mechanical integrity, and that can then go on to an actual tear. Collagen itself is a triple helix. There is normally a small amount of water embedded within the collagen, but it's so tightly bound that it does not give a signal on the typical MR sequences that we give. So normal collagen should be perfectly black on all of our traditional pulse sequences. If you go to really ultra short TEs or UT sequences, you can pick up signal from these bound water, but not with our traditional sequences. And it should be dark really on all pulse sequences because it has a very short T2 time. And we'll talk in the physics lecture, we'll talk about why bound water molecules have a short T2. That'll be in a later lecture. When you get mild degenerative changes, you start getting fraying and tearing of the triple helix fibers. In those areas, you get more water, and also this water tends to have increased freedom of motion. And then on short TE images, we can start getting gray signal intensity, but on T2 weighted images, it's still black. And therefore, looking at T1 short TE images and T2 long TE images can allow us to kind of grade the degree of degenerative change. If you have a mild degree of increased signal intensity on short TE images, but it's black on T2, that's still mild to moderate degrees of degenerative disease. Once you start seeing increased signal intensity on the T2 weighted images, then you're dealing with a lot more free mobile water, and you start talking about severe degenerative disease. And severe degenerative disease leads to a significant increase in the risk of tearing the tendon because it's associated with decreased mechanical strength of the collagen fibers. And so here's what more severe degenerative disease would look like: marked disruption of the collagen fibers, a lot more water, a lot more freedom of the water, so you get increased signal intensity on short TE images, and you start detecting signal on T2 weighted images, long TE images, and this is very severe degenerative disease. Then that can go on to lead to where you have tears in the tendon itself, where you have pockets of fluid that collect within the tendon, and then you've got areas that are that can be quite bright on the T2 weighted images. These areas tend to be bright on the short TE images also, not because the free water is bright. The free water is dark on a T1 weighted short TE image, but there's a lot of imbibition of water molecules in the adjacent abnormal collagen, which gives a signal even on the short TE images. What happens here, and this is true of a lot of injury of the soft tissues and typical of overuse injuries throughout all sports, is you get repetitive trauma, you start getting a biochemical breakdown of the soft tissue fibers, especially collagen. The repair mechanisms kick in, but this leads to tendinosis and then partial tear. Then you can get a full thickness tear. And in the chronic situation, these areas of abnormal tendon that are frayed, you can get calcification in those, and they can lead to calcific tendinitis, which then can also create its own inflammatory condition, which can be highly symptomatic. And we'll talk about calcific tendinitis when we're talking about tendon disease here. And actually, histologically, if you look at a series of torn tendons, histologically, these people found that all torn tendons have evidence of tendinosis in the adjacent tendon. So it's very difficult to tear a normal tendon. And that's why young kids almost never have tendon injuries. They tend to avulse the tendon off the bone or have bone fractures because the weak link is not in the normal tendon. The weak link in kids is in the bone. In adults, the tendon can tear, but that's because the tendon's abnormal and you develop degenerative disease and tendinosis of the tendon. That weakens it enough where the tendon can become the weak link. But that's more of an adult disease. So what do we know about rotator cuff tears? We know that they're very common. If you look at cadavers, a third of all cadavers will have partial or full thickness tears of the rotator cuff. So by the time you get old enough where you're a typical dead person, you're really likely to have tendinopathy of the rotator cuff. As opposed to what was thought back in the 1980s with Neer's theory of impingement producing rotator cuff tears, what we now know from cadaver studies is that most tears predominantly are on the articular side, not the bursal side. And therefore, it's now believed that most of these tears come from a primary weakening of the tendon from overuse and stretching and tendinosis, which has developed over time. And that gets severe enough where then you can break down the tendon and produce a tendon tear. And that's especially true in younger people.
John?
Yes, John.
What I was reading in Campbell's, they were talking about mid-substance being the main portion that's torn in degeneration.
Yeah.
So it's more like an interstitial tear as being the most common.
Yeah, that's probably true with MRI studies because we can see the interstitium.
They didn't say which.
This was a study done in cadavers where they probably can't see the inside of the tendon; they can only see the surfaces. And so when the surface,
this is probably an old study then.
Yeah, this was a few years ago. I should have the reference down here. I'm sorry, I don't. My guess is probably about 10 or 15 years ago.
Okay.
So in cadavers, what we see is actually the articular side is more commonly involved than the bursal side, and therefore this led people to realize that impingement is not the primary cause of rotator cuff tears. And what they also found in overhead athletes, and this was not part of the cadaver study, 45% of overhead athletes who have MRIs have partial or full thickness tears. So it's clear that overuse is a significant degenerative disease in older people. Overuse in athletes are the primary causes of rotator cuff tears. So what does a rotator cuff look like? Kind of a normal individual. This is a T1 weighted image on the left, a T2 non-fat suppressed on the right. These are old sequences. Here we can see the typical supraspinatus tendon. You can see the nice collagenous fibers. You can see that typical area of magic angle artifact, which is normal right here in this portion of the supraspinatus tendon, just about from 1 to 2 centimeters proximal to the supraspinatus insertion on the greater tuberosity. And on the T2 weighted images, it should be uniform in thickness and uniformly dark in signal intensity. So that's what the normal supraspinatus tendon should look like. When you start getting tendinosis on the T1 and the T2 weighted images, you start seeing increased signal intensity within the substance of the supraspinatus tendon, as we're seeing here. In this case, it's a more severe variety of tendinosis because we're picking up increased signal intensity on the T2 weighted images as well. So one of the main reasons I like to have T1, T2, and PD fat-sat images in this coronal plane is so that the T2 weighted image lets me grade the degree of tendinosis within the tendon, which is a risk for developing tears. And also, severe tendinosis like this can itself produce symptoms because you get abnormal stretching of the tendon, the nerve fibers, which are weave in and among the collagen fibers here. Since the collagen fibers are giving away and stretching, it irritates the nerve fibers when you put strain on a tendinotic tendon, and that can be a cause of pain, and therefore the T2 weighted image is helpful there. Now here's a T1 fat set and a PD fat set on an arthrographic stage. Here we can see that there's a little bit of irregularity of the inferior surface, and what we can see on the PD fat set image, we can see increased signal intensity within the interstitium of the tendon, and this is where there's tendinosis, which is what John was talking about the tendinosis being primarily interstitial, and you can see that here on the MR examination. And notice in this particular case, it's not taking up the contrast. If you have more degenerative disease, you can actually get contrast extending into the area of tendinosis, but we would see that on the T1 weighted image. So another reason why I like to do both T1 fat set and PD fat set is to differentiate what's imbibation of the contrast agent, the gadolinium, from what's native internal degenerative disease. And we can see that by seeing the differential signal between the T1 fat set and the PD fat set images. Yes, Dan?
Is that the rotator cuff cable that they talk about? Is that where that's supposed to?
Yeah. Now, the cable is more back in this region right in through here. And it tends to be a focal thickening. You see it some of the time and we don't at others. It's very obvious when we have that congenital anomaly where we have the pectoralis minor tendon coming across there, but that's really the pectoralis minor tendon. The rotator cuff cable is actually a thickening of the rotator cuff right in this location. If you look at arthroscopy or histologically, what it is a thickening of the collagen fibers that attaches at the anterior insertion of the supraspinatus tendon on the bone, then extends in kind of an arc back close to the musculotendinous junction, and then extends again to the insertion of the posterior fibers of the supraspinatus tendon. I think I have a diagram of this later. But this is probably this thickening of the collagen fibers right in this location, but it's very variable and we don't always see it on an MR study. I'm pretty sure I have the cable. Yes.
So if we could go back to the prior slide, so in this case you would say moderate tendinosis of the supraspinatus?
Yeah, in this case I would say that there's an inferior surface partial tear with mild tendinosis of the interstitium of the supraspinatus tendon, but that the partial tear involves less than 50% of the thickness, which generally would mean then it's a non-surgical lesion.
Now, if on the T1 you had matching high signal intensity so that contrast was imbibing into it, then you would just upgrade the partial thickness tear.
Well, it depends upon what it looks like. If it looks like that there is free flow into a defect, then I would say that it's an inferior surface partial tear associated with an interstitial tear. In this particular case, I would just say that there's some interstitial degenerative disease, but not an interstitial tear. I'll show examples of those later. Okay?
Thank you.
Okay. And then here's an example of what interstitial tendinosis looks like. This is moderate tendinosis, a little bit of increased signal intensity on the T1, no increased signal intensity on the T2, and increased signal intensity on the PD fat set. You can see that the deep surface of the tendon is intact along here. So this would look normal arthroscopically. We have a little bit of tendinosis of the tendon itself, but it's not severe because we don't see high signal intensity on the T2. So the reason I like to include the T2 is to be able to differentiate how severe the tendinosis is and what the risk would be for mechanical failure of the tendon. In this case, it's not severe tendinosis. Let's see. Why don't we actually stop here? I think this is a good stopping point, and we'll talk about further disease of the rotator cuff tomorrow, and then we'll take a hiatus for a week. Okay? Any questions? All right. Thanks everybody for joining.
Thank you.
Thank you. Have a good evening, everybody.
Thank you.
Thank you.